Welcome to the presentation for Nursing 150. This is a presentation covering Module 12, Assessment and Care of Patients with Ear and Hearing Problems. This presentation will review assessment of hearing, assessment of the outer, inner, and middle ear. It will review the anatomy and physiology of these parts of the ear as well. This presentation will also cover disorders of the ear such as an acoustic neuroma, Meniere's disease, hearing loss, different types of hearing loss, tinnitus, and vertigo. This is just a picture to review the anatomy and physiology of the ear. This is a picture of the outer ear. The external ear consists of the pinna and the ear canal. The pinna is the visible portion of the outer ear and is composed primarily of elastic cartilage covered with skin and very fine hair. This is a visual picture just to concentrate on the middle ear and the inner ear. The eardrum separates the external ear and the middle ear. The middle ear consists of a compartment called the epitympanum. Located in this area is the Eustachian tube and three small bones known as the bony ossicles. The eardrum is a thick sheet of tissue. It's transparent, opaque, or pearly gray and moves when air is injected into the external canal. The inner ear is the other side of the oval window and contains the semicircular canals, the cochlea, the vestibule, and the distal end of the eighth cranial nerve. The semicircular canals are tubes made of cartilage and contain fluid and hair cells. These canals are connected to the sensory nerve fibers of the vestibular portion of the eighth cranial nerve. The fluid and hair cells within the canals helps maintain a sense of balance. And this is just a closer look at the eardrum or the tympanic membrane. And this is the portion that separates the external ear and the middle ear. The eardrum is a thick sheet of tissue. It's transparent, opaque, or pearly gray and moves when air is injected. The assessment of a patient's hearing begins just from observation and conversation with the patient, just listening, just observing how the patient hears you and is able to answer questions. The patient's posture and responses can help you understand if the patient is having difficulty with hearing. If the patient tilts their head to one side when they're trying to listen to you, that could indicate some hearing disturbance in one ear. Other indicators, if they frequently have you repeat what you're saying. Determine whether the patient's able to respond to any whispered questions or typical questions. During the interview, make sure you sit in adequate light and face the patient to allow him or her to see you speak. It's important to identify that there are common age-related changes in the ear and hearing as a patient grows older. The hair in the canal becomes coarser and longer, especially in men. Cerumen is drier and impacts more easily, reducing hearing function. The tympanic membrane loses elasticity and may appear dull and retracted. Hearing acuity just decreases in most people as they grow older. And the ability to hear high-frequency sounds is lost in older adults. Some medical history such as ear trauma, past ear infections, excessive cerumen, air travel, swimming habits can all lead to a deficit in a patient's hearing. It's always important to assess your patient's family history. Sometimes hearing loss can have a familial tendency. If they're having hearing problems, asking about if anyone else in their family has had hearing problems as well. Physical exam for a patient with hearing loss problems. A very thorough exam is typically done by a physician or advanced practice nurse. But the nurse can there's some assessment that the nurse can do to kind of determine a degree of hearing loss. Begin by assessing the external ear for shape, looking to see any malformations in the pinna on the external portion of the ear. Look for swelling, nodules, or lesions. Some nurses are trained to use an otoscope. An instrument called an otoscope is used to examine the ear. It consists of a light, a handle, a magnifying lens often, and the purpose is just to examine to look for patency of the external canal, identify any lesions or excessive cerumen in the canal. If the patient has pain during the external ear exam, be very cautious, and you might have to stop the exam if it's very painful for the patient. Especially if it becomes in contact with inflamed tissue, it will be very painful for the patient. So that could be an indicator that there is some kind of problem if it causes them severe pain when you try to use an otoscope. They're going to tilt their head slightly away and hold the otoscope upside down like a large pin and kind of look in there. Observe the ear canal through the otoscope as you insert the speculum into the external canal to avoid the risk for perforating the eardrum. Audioscope is a test that involves the use of a handheld device to generate tones, various intensities, and just determine whether the patient can hear it or not. Tuning fork tests for hearing are the Weber and the Rinne test. These tests are useful in distinguishing between a conductive and a sensory neural hearing loss. And we'll talk about those specific hearing losses in the next few slides. Hearing loss can be categorized by conductive or sensorineural. Conductive hearing loss meaning that there is an obstruction of sound wave transmission, such as a foreign body in the external ear, which would maybe mean like a large amount of cerumen or some other thing that's obstructing the sound waves from getting into the inner ear. Sensory neural hearing loss is a result from a defect in the cochlea, or the eighth cranial nerve, or the brain. So again, it's talking about the sensorineural passage. Exposure to loud noise or music can cause this type of hearing loss by damaging the cochlear hair. A patient can certainly have mixed. They can have conductive and sensorineural hearing loss, such as in an older adult might have both kind. A tuning fork that we talked about in the last slide can do a Weber or a Rinne test. The Weber test is where you place a vibrating fork in the middle of the patient's head, on top of their head, and you're asking whether they hear the sound, the vibration sound, stronger on one side than the other. And then the Rinne test is looking at comparing how the patient hears by air conduction as opposed to bone conduction. So sound is normally heard 2 to 3 times longer by air conduction than by bone conduction. So what they do to perform this test is place a vibrating tuning fork stem in the mastoid process. So they hold the stem on that bone right there by the ear, which is known as the mastoid process, and they ask the patient to indicate when the sound is no longer heard. When the patient no longer hears the sound, they bring the fork forward and just hold it right outside the ear, which would be air conduction. And they ask the patient to tell them when they can no longer hear the sound. The patient normally continues to hear the sound 2 to 3 times longer in front of the pinna after not hearing it with the tuning fork touching the mastoid process. So again, it's looking at, do they hear it longer with air conduction or bone conduction? Kind of helping the provider to determine if they're having more of a bone conduction problem or air conduction. There's a good table in your book that does a comparison for features for conductive or sensorineural hearing loss. There's a term that refers to the sensorineural auditory sensory perception loss that occurs with aging. It's called presbycusis. Presby being a term that refers to aging. So presbycusis is just referring to the change in hearing, the sensory neural hearing loss that occurs with aging. This is just a picture to visually kind of think about. So conductive hearing loss means if there's some kind of an obstruction here. And then a sensory neural hearing loss means that there is some kind of issue with like the cochlea, if they're damaged by loud noises, the hairs in the cochlea, or if there's something going on with the eighth cranial nerve. Sometimes an acoustic neuroma, which we'll talk about, is a tumor that occurs somewhere over here and can press down on the eighth cranial nerve, causing a patient to have hearing deficits. That would be a sensory neural hearing loss. It's important to identify which kind of hearing loss they have so that it can be treated appropriately. Sometimes a conductive hearing loss can be treated just by removal of the obstruction. This is an otoscope that we talked about as far as the physical assessment of a patient with hearing loss. You can take this, and it's got a light in it, and you can kind of look at that external canal of the ear and look at the tympanic membrane to make sure it's looks healthy. This is the Weber and the Rinne. So this is A is the Weber, and then these two are the Rinne. So this would be that bone conduction where they're holding the tuning fork by the mastoid process, and then this would be the air conduction. So you should be able to hear it 2 times longer by air than you can by bone. As far as interventions for hearing loss, it's important to identify a patient who has hearing loss. Sometimes hearing loss may be gradual, and some patients may not even be aware that they have some hearing impairment. As with most other disorders, if it's identified early, sometimes we can do interventions early enough that we can prevent the hearing loss from getting worse. Protective hearing devices can be used for patients who maybe have occupations that expose them to loud noises. Also, teaching patients habits to prevent hearing loss. Make sure that patients know that they should not be sticking anything in their ear, especially Q-tips or toothpicks, into the ear canal. They can either damage their ear canal or they can push the rumen up against the eardrum and puncture the eardrum. If the rumen buildup is a problem, teach the person the proper technique to remove it, which can be irrigating, and they have to do this safely so that they don't damage the tympanic membrane. Other medical interventions can be identifying whether a patient has an ear infection and treating it appropriately with a proper antibiotic. Assistive devices for hearing loss, such as hearing aids, portable amplifiers for some patients. There are some nutritional changes that a patient can make, especially in a patient with Meniere's disease, and we'll talk about that more specifically when we talk about Meniere's disease. There is some surgery that can be done in the event that a patient has severe sensory neural possible cochlear damage. We can do cochlear implants. Make sure your patient will be educated in the event that they will be having surgery. Or if a patient is using hearing aids, they need to know the proper use and care of their hearing aid as far as batteries, how to turn it on, how to keep it dry, and how to just manage their hearing aid in the event that they require one. There's a good chart in your book about hearing aid care. It's a good idea to review that, about changing the battery, checking the connection, making sure it's on and off when it needs to be, adjusting the volume, and other things like that in the care of a patient that needs a hearing aid. There are other interventions that can be done as far as hearing loss, lip reading, sign language, speech therapy. Those are all community resources that we need to make sure that we consider as an intervention for a patient with hearing loss, and making sure they get the referral that they need in the event that they need it. Hearing loss can have a pretty significant psychosocial aspect due to the fact that it can be a communication problem, and it can be isolating. When they have trouble communicating, it could make them withdraw from society, and could lead to some depression. So it's important to help them get the resources they need to maintain independence and to be able to continue to be functioning adults. As far as doing any diagnostic tests for hearing loss, there's no lab tests that can diagnose a hearing loss, but some can indicate problems that affect hearing, such as maybe an infection, which could indicate an otitis media, which would be an ear infection, anything like that. Imaging would be possibly a CT scan. We could look to see if there's an acoustic neuroma, which would be a tumor that could be pressing on the 8th cranial nerve that could cause sensorineural hearing loss. We could look for, just any abnormalities that could be obstructing the hearing, anything like that. Any kind of soft tissue involvement would appear on a CT scan in the event that we need to do one. Of course, your auditory assessment, very focused assessment. There's a good example of focused assessment for the patient with suspected hearing loss in your book. It talks about assessing pain, feeling of fullness or congestion in the ear, dizziness or vertigo, tinnitus, which is ringing in the ears, assessing visible ear structures, assessing functional ability by some of those tests that we were talking about earlier as far as the Rinne and the Weber and the Otoscope. Audiometry can help determine whether hearing loss is also conductive or whether it has a sensorineural component. This is important in determining possible causes of the hearing loss and in planning interventions. Tympanometry assesses the mobility of the eardrum and structures of the middle ear by changing air pressures in the external ear canal. The progression or resolution of serous otitis and otitis media can be accurately monitored with this procedure. This test is helpful in distinguishing middle ear problems, otitis media or perforation of the eardrum, which would be a conductive hearing loss issue. And this is just a list of some specific hearing and ear disorders that we're going to talk about for Module 12. These are just specific disorders that we're going to talk about for Module 12. They're conditions that affect the inner ear, tinnitus, vertigo, Meniere's disease, and acoustic neuroma. And we'll talk about these and more focused in the next few slides. This is a picture. You can see the arrows pointing at what is known as a acoustic neuroma, which is a benign tumor of cranial nerve 8. It often damages other structures as it grows. Depending on the exact size and location of the tumor, damage to hearing, facial movements, and sensation can also occur. The patient can often experience tinnitus and vertigo as the tumor grows, as it presses on other areas in the brain. It can cause multiple different deficits in the patient. It's important to identify it early and treat it early. A tumor is diagnosed with a CT scan or MRI. Cerebral spinal fluid assays might show increased pressure and protein. Surgical removal can be performed in a variety of ways. Care is taken to preserve the function of the facial nerves and the cranial nerves. Tinnitus is a condition referring to a common ear problem that can occur in one or both ears. Tinnitus can range from mild ringing to a loud roaring in the ear, which can interfere with thinking and attention span. Some patients may feel as if the constant ringing is really frustrating and makes them really kind of a little bit crazy. Factors that contribute to tinnitus include age, sclerosis of the ossicles, which are those bones in the inner ear. Meniere's disease is a common cause for tinnitus, which we'll talk about. And there are certain medications that can cause tinnitus. Aspirin is pretty famous, and aspirin toxicity can cause ringing in the ears. Some of those aminoglycoside antibiotics, if you recall, can cause some toxicity in the ears. So it can cause ringing in the ears if there's toxic levels of aminoglycoside antibiotics. Exposure to loud noises can also cause ringing in the ears, known as tinnitus. Typically, when a patient complains of tinnitus, we will try to find the underlying cause and manage the underlying cause, and that should be effective in treating tinnitus. Vertigo and dizziness are common manifestations of many ear disorders. Again, you can have vertigo with Meniere's disease, which we'll talk about more specifically. Vertigo is often used interchangeably with dizziness, but there is a definition that they do have different definitions. True vertigo is a sense of whirling or turning in space, so it's a profoundness where they feel like they're whirling and turning. Dizziness is essentially just kind of a little bit of a disturbed sense of a person's relationship to space. So vertigo would be a little bit more intense in the fact that it makes the patient feel like they're whirling or turning in space. Vertigo can be associated with nausea, vomiting, falling, nystagmus, or hearing loss, so it's a little bit more intense feeling than dizziness is. The thing with why this is associated with hearing is because it often has affects the semicircular canals, which is balance, and the balance between the fluid and air in the inner ear can affect your feelings of dizziness and vertigo. That's why it's usually secondary to possible Meniere's disease or labyrinthitis or an acoustic neuroma. So moving in more specifically to discuss Meniere's disease. Meniere's disease usually first occurs in people between ages of 20 and 50 years old. It's more common in men. The symptoms occur due to an excess of endolymphatic fluid that distorts the inner ear canal system. This distortion decreases hearing by dilating the cochlear duct. It causes vertigo because of the damage to the vestibular system and stimulates tinnitus. At first, the hearing loss is reversible, but repeated damage to the cochlea from increased fluid pressure leads to permanent hearing loss. So essentially, if you go back to your anatomy and physiology of their inner ear and you look at the fluid balance that is required for the pressures in the ear, etc., this is when there's just too much fluid in that inner ear, and so it upsets the balance and it causes hearing loss due to the pressure that the increased fluid does. And the vertigo and the tinnitus is associated with disruption with that inner ear system that maintains our balance. Meniere's disease, it does come and go. So it occurs in attacks that may last for several days. The hallmark signs of Meniere's disease, which I already kind of said, is hearing loss, vertigo, and tinnitus. We're not really sure what causes Meniere's disease, but we do know that there is some interventions that a patient can do to prevent the attacks. Nutrition therapy, it's called a high drops diet, may stabilize body fluid levels to prevent this excess accumulation of fluid. The basic structure of this diet is distributing food and fluid intake evenly throughout the day, avoiding food or fluids with high salt content, drinking adequate amounts of fluid but spreading them out throughout the day instead of one big intake at one time, drinking adequate amounts of fluid, limiting alcohol and caffeine intake, and avoiding MSG. Coordinate with a dietitian for more information about diet therapy for reduction from Meniere's disease is always helpful. Lifestyle changes such as teach patients to move the head slowly to prevent worsening of the vertigo. Encourage patients to stop smoking because of the blood vessel constricting effects can help. As far as drug therapy, we can reduce the vertigo and vomiting and restore normal balance using mild diuretics. So this will get rid of some of that excess fluid in the endolymph system. Nicotinic acid has been found to be useful because it has a vasodilating effect. Some antihistamines such as Benadryl sometimes can help. And then some anti-vertigo drugs such as meclizine can be helpful and reduce the severity or stop an acute attack. And then antiemetics such as like Phenergan or Thorazine to kind of help the nausea. Some patients really become non-functional because they have so many attacks, and so they may require surgery. And this would be a total removal of the labyrinth, which is a labyrinthectomy. It's performed through the ear canal. This procedure results in total auditory sensory perception loss on the operative side, so it would be the last resort. Meniere's disease, in a patient who has several attacks, it can cause permanent hearing loss. And so, like, that surgical intervention would be somebody who's having so many attacks that they're beginning to have hearing loss, and that they're having trouble functioning. And so, it's often helpful for us to really teach people how to maintain their attacks and prevent their attacks first, because of the risk for them having permanent hearing loss due to the attacks of Meniere's disease. So make sure you kind of review what you could do to help a patient prevent the attacks and then lessen the severity of the attacks. Different things. They can go lay down in a quiet room, to kind of decrease any stimulation that can decrease their vertigo and their nausea. That can be helpful, just teaching them things that they can do to kind of decrease their symptoms and decrease the severity of the attack. The following slides are practice questions and case studies to review what you have learned regarding a patient with ear and hearing disorders for Module 12 in Nursing 150. The answers to these can be found in the PowerPoint posted in the additional resources. I encourage you to attempt to answer the questions and then check yourself with the PowerPoint answers. This concludes a presentation for Module 12, Caring for a Patient with Ear and Hearing Disorders.